Hello, and welcome to the CAP Today webinar for Tuesday, June 10. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host and then moderate a question and answer session after our formal presentation. Today's webinar is entitled Shifting HERizons, Navigating the Evolving Landscape of HER2 in Breast Carcinoma. As we all know, this is a very timely and a very critical topic right now. It's featured prominently in our titles, featuring prominently at all the cancer meetings, and we couldn't be more delighted than to bring you a webinar on this topic today. We're very, very grateful to Roche for their educational grant that's allowed us to present this program to you today. And so we want to acknowledge Roche and thank them for their support. It's very critical to enable us to bring this to you. We have a single speaker today, a very distinguished young pathologist, Dr. Raza Hoda. He's a staff pathologist at the Cleveland Clinic, an assistant professor of pathology at the clinic's Lerner College of Medicine. He trained at the Mass General and did fellowship in breast pathology at the Memorial Sloan Kettering. And yes, he is related to the very famous Dr. Hoda that you all know and love in New York City. In fact, both of his parents are pathologists. So it's a delight to have him here and to work with him. I know you're going to enjoy the presentation he's about to give you. But before I ask him to begin, I do want to go over a little bit of housekeeping, just to let you know what how you can optimize today. You'll see a pod in the website in front of you, and there you can type questions and comments throughout today's webinar. You can also use that pod to make requests for technical help. We have live technical help at any time for the website or for the audio, and that can be very useful. We will be posting the slides and the audio of this presentation in about a week, and you'll see that at captodayonline.com. I want you to know that you're likely to see a follow-up email from us and perhaps also from our sponsor, Roche. So I wanted to give you a heads up on that. Finally, it's important that I note that the CAP Today does not endorse any products or services that may be mentioned in today's webinar. And of course, any comments that I make are purely personal, not to be construed as the policy of CAP Today or the College of American Pathologists. And now with that, I'd like to invite Dr. Hoda to begin his presentation, Shifting HERizons. Dr. Hoda.
Thank you, Bob. Thank you for that very kind introduction. I appreciate it. It's been great getting to know you and getting to work with you. I want to thank Cap Today for hosting this event. I want to thank our friends over at Roche for sponsoring the event, as Bob had mentioned, and I want to thank you all for joining today. So I'm glad that HER2 is on everyone's tip of their tongue. You know, this has been an area of interest of mine for nearly a decade, and I'm so glad that everyone has found out how cool of a protein it is and how much it's really changed not only patients with breast carcinoma, but really patients with all sorts of tumors now with the latest FDA approvals of tumor agnostic. So I'm glad to share you my perspective, in terms of a breast pathologist on the evolving landscape of HER2. And with that, we can start. Here's a brief disclosure that I have. The additional disclosure that I have is this. This is a rapidly evolving field, and I have tried to make it as up-to-date as possible. That being said, who knows? Even at the end of this presentation, some trial data can come out, and all of this is completely out of date, and we have a new look on the HER2 assay and what HER2 status means in breast carcinoma. But I have tried to make it as up-to-date as possible. Here's an outline of what we're going to talk about. First, we'll review ERBB2 and HER2 and breast carcinoma. We'll then talk about some of the advances in HER2 targeted therapy, certainly one of the reasons why we're meeting today on this topic. Many of the quick changes that we've had in therapies, certainly with antibody drug conjugates, and discuss basically the various ways that we have targeted HER2 in breast carcinoma over the years. Hand in hand with that, we'll talk about the evolution of HER2 testing from our standpoint as pathologists. Certainly, HER2, as we talk about, has a lot of ramifications for patients in terms of their prognostic and predictive value, and can really have a dramatic outcome on a patient's therapy in breast carcinoma. And lastly, we'll talk about some future directions, and we'll have some time for questions. With that, we can start. So what is HER2 exactly? Well, when we look at breast cancer and breast carcinoma in general, we're really looking at a very small subset of breast carcinoma that is driven by HER2 or HER2 positive, really on the order of 15 to 20%, depending on the studies you look at and the patient populations. We're looking at that size of the pie when you look at all breast carcinomas. That leaves about 85%, 80% or so that are driven by other drivers, such as hormonal or otherwise. But really, we're looking at that 15% of patients who are driven by HER2. Um, and as we'll look at today, we'll revisit this pie and we'll see how we can expand that red portion of the pie and target that 85% that may be, especially in the metastatic setting, in need of another therapy. Maybe at some level, not only just driven by HER2, but expressing it, even at very low levels. How does it work? Well, the mechanism of ERBB2 and HER2, very simply put, is on the left. If you're not biomedically inclined, HER2 activity leads to increase in proliferation, motility, quote unquote invasiveness, resistance to apoptosis, and angiogenesis. And these are the fundamental foundational blocks that really are the key mechanisms to oncogenesis, right? This is all what you need to be the greatest cancer cell of all time, right? You need to proliferate, you need to be motile, you need to metastasize, you have to invade, you have to resist the urge to undergo apoptosis and give yourself some blood supply. In a more molecular level, here we have on the right a cartoon of the HER2 transmembrane protein. You can see here it's a tyrosine kinase receptor. And when activated, it leads to further activation downstream of the RAS-RAF pathways, the MEK-ERT pathways, the PIK3CA pathway, the PIK3 kinase pathways, AKT, mTOR. And all this leads to cyclin D1 overexpression, RB1 phosphorylation, and unlimited cycling of the cell cycle. And these are all really all you need to be a surviving breast cancer cell. And you can see just in those 15% of patients how much it can really devastate the human body. And just a little timeline, I do like history. So just to share with you where we get the name ERBB2, where we get the name HER2, it all starts really in 1935 with the discovery of the ERBB gene and protein in avian erythroblastosis retrovirus. So you can see that's where we get ERB from. Then about 30 years later, we discover EGF or epidermal growth factor receptor, or epidermal growth factor. Then in the 70s, we have description and discovery of oncogenes, much like HER2, some of the fundamental pathways that are hijacked by cancer cells in order to overcome apoptosis and undergo uncontrolled cell proliferation. We then in 1978 discover EGF binds to its receptor, EGFR, that leads to cell growth. Then in the mid 1980s, we get ERBB2 on the block. That's known as NEW because it's found in rat neuroblastoma. And it's located on chromosome 17. It's distinct, but similar to EGFR in that it, really leads to cell growth, as we talked about. And the other name for EGFR is actually HER1. So you can see the similarities between the two structures, even in name. Then in 1985, in Dennis Slamon's group over at UCLA, we get the identification of the oncogenic function of ERBB and HER2. Furthermore, in that group, we get the clinical significance of ERBB2 and HER2 in breast tumors. And then in the early 90s, we get the development of the humanized monoclonal antibody HER2, known as trastuzumab. So you can see, just even in a span of less than 100 years, 60 or so years, we get the discovery of a protein in an avian erythroblastosis retrovirus to actually being able to identify the clinical significance and target it with actual medication to really change the landscape of breast carcinoma. So it really is a remarkable timeline. You can just see how condensed it is around the mid 80s and the early 90s and how much changes in such a short span of time. Really is a remarkable story. And just to underscore the importance of these discoveries, the two highlighted in yellow here, the discovery and description of oncogenes and the description of EGF binding to its receptor EGFR were both awarded the Nobel Prize. So in breast carcinomas, we're looking at ERBB2 first as a prognostic marker, and that's what Dennis Lamon, his group really came into play and came into importance in finding out. So it was recognized not as a good prognostic marker, actually it was associated with adverse outcomes. So over here on the right, we can see two Kaplan-Meier curves. On the top, we have disease-free survival, and on the bottom, we have overall survival. And these are patients who have amplification or non-amplification of HER2 in their breast carcinomas. And just highlighting here, the amplification in the 1980s was defined as greater than 5 copies of the gene. And even having 5 copies at this point really shows poor prognosis for both disease-free and overall survival for patients. And you can see that this was really a bad marker to have in the 80s and early 90s, and it really did change after that. So looking at the same patient population here, the node-positive patients that are HER2 amplified, again, on the top, we have disease-free survival probability. At the bottom, we have overall survival. If we look shortly after, around 30 years or so, in 2009 with the FNCL-CC PAX-04 trial, again, node-positive patients with HER2 amplification, you can just see how much that curve, the disease-free survival curve and the overall survival curves have changed dramatically, and even more so than those that are non-amplified. And if you're a Swiftie out there like me, you can think about it in terms of eras. So the pre-trastuzumab era and the post-trastuzumab era. And you can just see how strong of a predictive factor HER2 has now become. And actually, it was one thing that we used to say, oh, well, the patient's HER2 amplified, this is going to be bad news, to something that we celebrate. When we have a core biopsy that shows HER2 amplification, that means that patient will get neoadjuvant trastuzumab, THP, and will actually have an excellent outcome thanks to the developments of drugs like trastuzumab. With that, we can talk about the advances in HER2 targeted therapy. So there are basically 3 ways that we can attack HER2. The first, trastuzumab, as we mentioned, belongs to the anti-HER2 monoclonal antibody. Then we have HER2 tyrosine kinase inhibitors. As we mentioned, HER2 is a tyrosine kinase receptor. And then we have the latest kid on the block, the reason why we're all here today, the anti-HER2 antibody drug conjugates, or ADCs. We'll talk about how each one of these work and how they have an effect on tumor cells. So the first, the OG, trastuzumab, is an anti-HER2 monoclonal antibody. You can see here interacting with the extracellular domain of the tyrosine kinase receptor of HER2, shown here in this cartoon. We have the plasma cell membrane here in the gray. We have the cytoplasm in this gray gradient below. And trastuzumab, margetuximab, pertuzumab, these all attack and attach to the HER2 extracellular domain. This interaction then leads to the actual receptor being ingested by the cell and undergo lysosomal degradation. And that actually just removes the HER2 receptor at the cell membrane level and leads to further inhibition of the downstream signaling. So it really does convert a HER2 positive cell, if you think about it at the cell membrane level, to a HER2 negative cell. So very powerful, very potent drug, especially for HER2 positive. And here I've shown you a timeline again. The years here indicate when each drug was FDA approved. In the parentheses, I've shown here the indication for each one of those approvals. So trastuzumab, first kid on the block, 1998, approved in the metastatic setting. Shortly thereafter, about 8 years or so, we have trastuzumab in the adjuvant setting. We still use it today. Then we have pertuzumab in the metastatic, neoadjuvant, and adjuvant settings. Then we have medications I'm not even going to try to say. It's very long, but essentially you can use it in the metastatic and adjuvant settings. And why are there so many different versions, even in the same class? Well, just to show you the steady improvement that we make through scientific advances, through drug development. This is a Kaplan-Meier curve shown here on the left from the original trastuzumab trial. Here on the bottom, at the clear boxes, we have chemotherapy alone arm. These are patients with metastatic breast carcinoma that are HER2 amplified. So we have patients with chemotherapy alone at the bottom here, and this curve is showing you progression-free survival, and you can just see the improvement in progression-free survival in patients who are HER2 amplified with the addition of trastuzumab to that chemotherapy regimen. So really is quite remarkable in terms of its as a response. And we saw not only an adverse predictive marker, but really a very potent, powerful prognostic or predictive marker. And here I've shown you the latest from the SOPHIA trial in 2022. This is showing you in the orange line, that same black line from the original progression-free survival line and in the trastuzumab trials. It's just showing you the incremental progression or progress that we've made in terms of progression-free survival with margetuximab and chemotherapy. And you can just see, even with this new addition, so same sort of therapy, same sort of modality and how it works in terms of monoclonal antibodies, it leads to a overall about a quarter risk reduction in terms of disease progression. And again, we're talking about patients who are HER2 amplified, who are widely metastatic, really offering no other options, really pushing that boundary forward and showing incremental changes in terms of progression-free survival. Even in here, showing you the median increase by about 3 months or so. So the next class here, we have tyrosine kinase inhibitors. This again here, as opposed to attacking the extracellular domain, here attacks the tyrosine kinase domain, which is located inside the cell. That interaction of things like lapatinib, neratinib, these attack the tyrosine kinase domain, attach, and actually then inhibit the possibility of activating those downstream signals, like the MAP-ERK pathway, the MEK-ERK pathway. So this is just another way that you can attack the HER2 kinase domain. Just showing you the various classes of the various different names of the medications that we have here, the different iterations. We have lapatinib that first came out for the metastatic setting in 2007, followed by neratinib and tucatinib. And just showing you the various changes and the progress that we've made with the various medications. You can see we even had a improvement in naming trials. The EGF 100151 trial, that is rolls right off your tongue. For lapatinib, you can see capecitabine alone versus lapatinib plus capecitabine. The progress that one makes when you receive lapatinib versus capecitabine alone in terms of disease-free progression, we're looking on the order of about 4 months or so in terms of progression-free survival. And then you see the most latest from the NALA trial, a little bit easier to say in terms of neratinib. We see again here in the metastatic setting, patients who are HER2 positive. The improvement, lapatinib here plus capecitabine shown here in the red, so the same line shown here in the black from the other Kaplan-Meier curve. And you can just see the incremental changes made by adding neratinib plus capecitabine. And here looking on average about 2.2 months or so in terms of progression-free survival. So really excellent, even on the order of 15 months or 15 years or so, showing that incremental progress that we've made even within the same drug class. And then lastly, the reason again why we're all here, the antibody drug conjugates. So these both combine the power of the monoclonal antibody like trastuzumab and a chemotherapy drug payload. So here, that's where you get the name antibody drug conjugate. So shown here in this cartoon, we have the monoclonal antibody to HER2, such as trastuzumab here, attacking the extracellular domain of HER2 receptor. You can see that it then gets internalized by the cell, gets swallowed by an endosome, undergoes lysosomal degradation, where that chemotherapy payload then gets released into the cytoplasm, arresting cell development, leading to cell death. And then once the cell actually dies, that chemotherapy is still within the tumor milieu, and that's known as the bystander effect. So really is quite powerful. And unlike the other drugs, not really using HER2 in terms of, removing it from the cell membrane as the monoclonal antibodies do, not only just attacking the tyrosine kinase domain, so really kind of suffocating the driving force of the tumor, but really just using it as a homing signal. And whether or not you have 10,000 copies of HER2 at your cell membrane, or even 1,000, it's simply using it as an address to deliver the chemotherapy payload. And that's where we see that remarkable improvement versus the other medications, even at low levels of HER2 expression, not only just HER2 amplified tumors. So looking at the timeline again of all the iterations of antibody drug conjugates, these are by no means new. We've had them for about 10 years or so. So the first one on the market, TDM1, coming in around 2013, with then the latest ones being in the HER2 low and in the hormone receptor positive HER2 ultra low setting. So really is quite remarkable where we're not only just using it for HER2 positive tumors, but also looking at those that are quote unquote HER2 negative, such as low and even very low levels of expression in terms of ultra low. And that's the most latest FDA approval here in 2005. So again, going back to the Kaplan-Meier curves, looking at the Amelia trial in 2013 on the left, we can see lapatinib versus capecitabine in the red and TDM1 on the right, or TDM1 is on the right of that in blue. And you can see that with the addition of TDM1, we had an overall increase in progression-free survival. We're looking at a median of about 3 months or so. So really fantastic news for patients who have widely metastatic HER2 positive disease. And then more interestingly, on the right hand side, we have the progression-free survival curves in the HER2 ultra low patients. So these are hormone receptor positive, HER2 ultra low, and these are widely metastatic patients. And you can see this is from Destiny Breast 06 trial, and you can see that the addition of chemotherapy, of trastuzumab deruxtecan, the improvement on the order of about 5 months or so in terms of median progression-free survival versus chemotherapy alone. So these are patients who have hormone receptor positive disease. They're widely metastatic. They really have no other choice besides non-specific cytotoxic chemotherapy. So you can see just using that trastuzumab anti-monoclonal antibody, using it as a delivery system really has a profound effect on a patient's outcome in terms of progression-free survival. And with that data, the FDA went ahead and approved this medication for those who are HER2 ultra low in the hormone receptor positive setting. So again, just looking at a timeline with all our medications that we have, this is really a vast armamentarium that we have to attack HER2, not only those that are driven by HER2, as we saw, but also those that even have very low levels of HER2, especially in the ultra low setting. So really just a fantastic amount of medications that we have, all aiming towards HER2 positive and HER2 expressed tumors. Really is a remarkable story, even within the span of 30 years or 20 years or so. So again, just looking back at our original pie chart, as we saw, about 15% or so of patients have HER2-driven breast carcinomas, and about 85% or so are HER2 negative. Is there anything that we can do, especially now that we have the antibody drug conjugates? How much of this pie is now able to be affected by those improvements? And you can see that when we're looking at HER2 low, we're really increasing that pie by over half. So about 55% of patients are shown to be HER2 low, and these are patients who are, either driven by hormone receptor or otherwise, or triple negative tumors, and really is expanding the amount of patients that we can use, especially with the ADCs. That still leaves about 30%, and we're going to revisit them in just a moment. So again, focusing on the HER2 low patients, these are looking at the Kaplan-Meier curves for progression-free survival in both hormone receptor positive and in all patients. You can see that trastuzumab deruxtecan versus physician choices in this randomized clinical trial showed a remarkable improvement in terms of progression-free survival. We're looking again on the order of 5 months or so for both those that are hormone receptor positive and all comers. So really fantastic news. The bottom would be even including patients who are triple negative. So really outstanding. Again, revisiting that pie chart, anything we can do about the 30%? Well, I'm glad you asked. About 20% of those patients are HER2 ultra low. So really just a remarkable change in how we approach HER2 with those new ADCs. We're not just looking at those that are HER2 addicted, but really those that we can use even at low levels to deliver systemic chemotherapy. So really outstanding, and leaving 10% or so of patients who are HER2 null or having no expression of HER2. So looking at, again, that latest Destiny Breast 06 trial, so the DB06 trial, this is looking at hormone receptor positive patients with metastatic disease and HER2 ultra low patients. You can see that the addition of trastuzumab deruxtecan improved progression-free survival on the order of about 5 months or so. So really fantastic news, and I'm glad that these patients have the ability to use this medication and have some hope in terms of their fight against breast carcinoma. So revisiting that pie chart again, looking at about 15% or so that are HER2 driven and 85% that are HER2 negative, and more thinking about of those that are HER2 actionable or non-actionable. And really just remarkable in how we have the inverse pie chart now in a brief span of time. We're talking about really 5 years or so, and how we think about HER2 in terms of tumor biology and drug delivery. So really remarkable, and leaving about 90% of patients who are able to benefit from these antibody drug conjugates, about 10% who are still we're still waiting to see what we have here. But that's still a remarkable improvement from the 15% that we had before. This is just the new treatment paradigm now in the metastatic setting. This is just a look at how we treat our patients here at Cleveland Clinic. So I've divided into the various different kind of receptor profiles that a patient may have. So if you have metastatic hormone receptor positive, HER2 low or ultra low, you may be given a PARP inhibitor if it's applicable. You may be given capecitabine, or you may be given trastuzumab deruxtecan. If you're hormone receptor negative and HER2 low, you may be given a PARP inhibitor, paclitaxel, or TDXD. And if you're HER2 positive, you may just be given THP, that's docetaxel, Herceptin, and pertuzumab, and TDXD as well. So really is a remarkable change in the kind of way that we approach each one of these tumors, especially in the metastatic setting. Now, it's not static by any means. This is a publication that my colleague, Dr. McIntyre, and I published earlier this year. This is looking at patients from our institution, 1 year of data, who had hormone receptor positive disease. And we looked at those who are all diagnosed with metastatic hormone receptor positive breast carcinomas. And we went ahead and looked at the HER2 status of their primary tumors as well as their metastatic tumors. Now, we weren't doing this upfront at the time, so we went ahead, we looked at all these tumors and gave it our score. We learned a lot of the challenges, certainly, of interpreting these tumors, but that's how we did get experience, at least. And you can see that it is by no means static. It's very dynamic, and you can see that if a patient had a primary HER2 low positive tumor, you may convert to HER2 null, ultra low. And likewise, with those that are HER2 ultra low and null in the primary setting, you may have some expression HER2 ultra low and low in the metastatic setting. And this is more, maybe due to sampling, maybe due to tumor heterogeneity, and a variety of different factors, even fixation times, in the reason why, these assays weren't really designed for testing all these low levels of expression, and that you may benefit from actually testing multiple specimens from the same patient in order to get some sort of way to get this patient into the TDXD arm of treatment. So with that in mind, we'll talk about some of the evolutions in HER2 testing from our standpoint as a pathologist. So this is basically how ERBB2 gene and HER2 mRNA expression and HER2 protein expression work in the normal cell. You can see that we all have 2 copies of ERBB2, whether we like it or not, located on chromosome 17. That has some level of, transcription into HER2 mRNA, and that leads to some expression and translation of HER2 protein at the membrane level. Whether or not that's applicable or identifiable with our current means is debatable. And then in the HER2 positive setting, so this is a tumor cell, a breast tumor cell that's driven by HER2, you can see we have amplification of ERBB2. You can see multiple copies of the gene here that leads to overexpression of mRNA, HER2 mRNA, and that leads to translation of HER2 protein at a large number at the cell membrane. And that's how you get that positivity, that strong, intense membranous staining with HER2 IHC. So there's no gold standard in how you test for HER2. They're just common accepted ways on how we do it in the laboratory. There's more feasible methods. This is just a sample of how you can approach HER2. You can do Southern blot like the original, and PCR like the original studies out of Dennis Lamon's lab. You can do IHC. You can do various forms of ISH, either through chromogenic ISH. You can do FISH through fluorescence, or you can even do next generation sequencing, as we showed at a study that I participated in at Memorial Sloan Kettering. You can use fold change for the gene expression in order to sort of predict HER2 IHC and FISH expression. But each one of those is going to be a topic in and of itself. So we're going to really focus on IHC, which is really the thing that has changed the most out of all of those modalities. So the various ways that you can use HER2 IHC, certainly we've shown it is a very strong predictive marker. We've shown it is an adverse prognostic marker for patients. We can also use it to molecularly subtype as a surrogate marker to show HER2 enriched tumors. You can also use it off-label as a diagnostic aid in terms of identifying Paget disease. Comes to mind in terms of the clinic. So the various ways you can use IHC for HER2. And we're giving Cap today presentation. This is look back in the archives. This is from October 1998. You can see this very catchy title, HER2 breast assay linked to Herceptin wins FDA's okay. Carl, I love your style in terms of journalism, and you can see that this is really, we're talking about the first companion diagnostic in breast carcinoma. Just as we see, PD-L1 today, this was a companion diagnostic for Herceptin, and really led to a lot of buzz even in CAP today. Now, between the time that it was approved to the time that officially the first ASCO CAP guideline for HER2 interpretation and testing came out, it really was a Wild West, and there was no standardization of HER2 IHC testing or even interpretation. And that may ring true for some people who are interpreting HER2 Ultra Low and PD-L1. It can be really challenging, especially without official guidelines. And so ASCO, the American Society of Clinical Oncology, and the College of American Pathologists got together and issued a joint guideline about 10 years after the first approval in the metastatic setting and about a year after the first approval in the adjuvant setting on how we should approach HER2 testing as pathologists and as oncologists as well. And some of the benefits of standardizing that reporting system are really the appropriate use of targeted therapy. We've shown how much benefit a patient can derive from HER2, but it really is in the appropriate setting, rather from trastuzumab, but it really is for those who are, HER2-driven tumors. And so making sure the appropriate patient gets the appropriate targeted therapy is essential in terms of, standardizing the reporting system. On the flip side, you also want to make sure that patients who don't need the medication aren't exposed to unnecessary medical side effects and financial toxicity. I was just at the San Antonio Breast Conference, and a lot of the presentations from the patient side were talking about, not only the medical side effects to these wonderful medications. We talk about progression-free survival, but not really, sort of, other side of things, the medical side effects, and certainly the patients and their families undergo that as well. And we're talking about also the financial burden that the family and the patient undergoes when they're going these very costly medications. Certainly, we also want to minimize the variability of the pre-analytic and the analytic factors. Reproducibility of the test results are essential, and consistent and reliable analytic performance is all what we strive for when we're issuing a correct interpretation or interpretation for HER2. So this is a publication from out of MD Anderson, a very large cancer center in Texas, and you can see they just delineated in this fishbone diagram all the various steps that are needed to ensure that the appropriate HER2 interpretation is given to the right patient. Things like even noting cold ischemic time and formalin, making sure that all our pathologists who are interpreting are professionally competent and undergo proficiency testing, even down to the laboratory, whether or not the tissue is fixated the appropriate amount of time, the thickness of the section is important, and that all leads to the appropriate interpretation going to the appropriate patient. Also, from that same study, they showed the importance of the intervention and the implementation of the first ASCO CAP guideline. Here in the orange dot, you can see after the first and second interventions and applying the standardized criteria and interpretation for HER2, just a vast difference. And the solid blue line is the percent of cases that were inconclusive for HER2. And just imagine, this patient is eligible for a wonder drug that will really change the progression-free survival, melt their tumor away, and you get an inconclusive result. It really is disheartening for the medical oncologist and certainly for the patient. And so giving a conclusive answer is part of standardizing HER2 interpretation. And this is just an excerpt from the paper that standardized fixation and adherence to the ASCO-CAP guidelines for HER2 testing has resulted in a greater HER2 IHC and HER2 FISH correlation and decreased number of inconclusive FISH cases. And this is just at a place that's has a large patient volume like MD Anderson, and I can only imagine what smaller laboratories all across the country were going through at that time. So here are the various guidelines that were issued from ASCO-CAP in a joint manner over time. The first one in 2007 increased the number of cells needed for a 3+ scoring for HER2. And that's just because it was such a powerful drug that ASCO-CAP felt that they needed to ensure that the right patient was appropriately scored, especially right around that low level expression. So they thought bumping it up and increasing the sensitivity and specificity to 30% was important. 2+ was defined as a weak membranous staining of greater than 10% of cells. FISH categories, there were 3 of them. The equivocal FISH result was based on the HER2 CEP17 ratio alone. But most importantly, it established technical requirements and required competency assessments. And we saw how much of that can really change even with that MD Anderson study. Then about 5 years later, ASCO-CAP revisited the 3+ score. So, I think they all understood that we got the gist of it. We understand what positive means, but really lowered it back down to the initial trastuzumab trials down to 10%. And that really then opened up the gates and allowed more patients to receive trastuzumab. 2+ was then included the definition complete intense membranous staining of less than or equal to 10% of cells. There were now 5 FISH categories. FISH equivocal was based on not only the HER2 CEP17 ratio, but also things like copy number of HER2 and the number of signals per cell. And then also offered some guidance on when to retest patients, certainly in the equivocal fashions as well. So that was really much needed guidance. Then 5 years later, we have a simplification of the 2+ back to a weak membranous staining of greater than 10% of cells. We removed, thankfully, the FISH equivocal results, and that again really is important to have a definitive answer one way or the other for a patient, for the medical oncologist, for who should get anti-HER2 therapies. And FISH also then incorporated the IHC results, which was really important in terms of the 2+ category. Then, sure enough, 5 years later, there was an update, certainly with all the new antibody drug conjugate therapies that were on the market. The ASCO-CAP guidelines felt that there shouldn't be any change to the HER2 IHC reporting. It affirmed the use of IHC as a predictive marker, ensuring that these scores had a biological basis and had nothing to do with the drug indications or clinical trial inclusion criteria, but recognizing that we're in a new environment and that there is importance in distinguishing 0 and 1+. And I can assure you that probably in 5 years, we'll have another, just like clockwork, another ASCO-CAP guidelines. Perhaps then we may have something about ultra low and null. So we're a large reference lab here at the Cleveland Clinic. I was on the receptor service yesterday. I had 30 HER2 IHC to interpret. Again, I don't mind it. It's one of my favorite things to look at. But you can just see here, this is a sample of the various different types of results you can get, even with the same assay, depending on the tumor type that you have. And we'll go through and we'll see how we can score each one of these. So under the ASCO-CAP grading paradigm, we have HER2 negative, that's 0 and 1+. We have HER2 2+ or equivocal, and we have HER2 positive at 3+. So score of 0 is defined as membranous, faint, barely perceptible staining that's incomplete and less than or equal to 10% of cells, or no staining observed. 1+ is defined as membranous, faint, barely perceptible staining that's incomplete in greater than 10% of cells. 2+ is membranous, weak to moderate staining that's complete in greater than 10% of cells. And these samples are then sent over to ISH, whether it's FISH or SISH, for further evaluation of the genomic status. And then 3+ is membranous, intense, complete staining in greater than 10% of cells. Under this new paradigm, if we're talking about patients' eligibility criteria to receive the ADCs, we have 4 scoring classifications. So we have HER2 null, ultra low, low, and positive. So 0, easy, No staining observed. 0 plus is membranous, faint, barely perceptible staining that's incomplete and less than or equal to 10% of cells. HER2 low is really 1 plus or 2 plus-ish negative. And positive are those that are 3 plus or 2 plus and positive by ish. So I'm active on social media. This is just a snippet from last week. I posted on Twitter or X, whatever you want to call it. I posted the same photo of a HER2 ultra low, and I asked my followers, "Do you report HER2 ultra low?" This is the internet, so people may lie. So take it with a grain of salt. This is also Twitter or X, so take it with even greater grain of salt. But I asked if they report HER2 ultra low. You can see that about a third out of the 117 who responded said yes. No was about 2/3 or 60%, and there were about 6% of people who didn't respond. So I'm curious out there how many of the people who are listening, whether or not they report HER2 currently. So just an approach on how you should, approach a HER2 IHC interpretation. These are adapted from the ASCO-CAP guidelines. First and foremost, right off the bat, you have to ensure that the pre-analytic factors meet ASCO-CAP guidelines. So we're talking about less than 1 hour for cold ischemic time, greater than 6 hours or less than 72 hours for fixation and 10% neutral buffered formalin. And these are essential. I mean, especially we're talking about low levels of expression, overfixation, underfixation can all have issues. Having a piece of tissue sit out for a number of hours can degrade the tissue, certainly in terms of its immunoreactivity and its antigenicity. And so these are all very essential when you're talking about pre-analytic factors for assuring that the patient has the appropriate IHC result. Offer a range of controls. This helps you keep on track and in line with your colleagues. Here at the clinic, we have a scanned every day, a 4-in-1 control for HER2 that has a 3 plus, a 2 plus, a 1 plus, and a 0 offered. And it's something that helps me keep in track, especially when I have 30 cases, just making sure I don't deviate from the norm. And it really is helpful to refer back at a ground truth. Absolutely, using nucleate slides is something that can help ensure the tumor antigenicity, especially less than 48 hours. Data show that slides that are older that are lying around, especially if it's something that, patient has metastatic disease, you want to go back to the biopsy, you have the unstains on file, just make sure that that you have, if you have the block, that you cut new slides and restain them with IHC. Then I also like to just review the morphology to just make sure it makes sense. Now, it really doesn't apply to HER2, more so for ER and PR. I like to play a game with my residents and fellows, make a wager, say, I think this will be ER positive, HER2 negative, or, triple negative. So looking at this tumor, I would expect it to be ER positive and HER2 negative. If I have an ER negative result, I'm going to take pause, make sure that there's an internal control, make sure that it actually worked. Or if I miss, maybe an unusual morphology like a salivary gland type neoplasm that's low grade and triple negative, or microglanduloadenosis. So it just helps me keep in check and make sure that things make sense. And if I have a high grade tumor, then that's 3 plus. That's not to say that HER2 can't be amplified in low grade tumors. It just is unusual. Likewise, I like to correlate it with the morphology, especially when I'm dealing with reference lab cases, where I wasn't the first pathologist who read the diagnosis. Things like apocrine carcinoma, notorious for having this granular staining pattern, can be really hard to actually see the membranous staining because that's all we really care about, right? If it's complete, if it's incomplete. And you can see here that if you subtract out the membranous, the cytoplasmic granular staining from the apocrine granules, that we really have incomplete staining of each tumor cell, and it should be scored as a 1 plus and not sent to FISH. Likewise, micropapillary carcinoma, notorious for one reason or another to not have complete membranous staining. I've noticed the same staining pattern for EMA, for E-cadherin. So maybe it's some sort of tight junction protein. It's actually the inverse of what EMA should be. So maybe there's some sort of interaction with HER2 and the cell membrane. Maybe there's a Nobel Prize in there for someone out there to investigate. But notoriously, micropapillary will have this U-cupped or basolateral staining pattern, so you won't have complete membranous staining. But AstroCap recognizes this as unusual, and it should be scored as a 2 plus. And actually, this case was HER2 amplified. So if you see this case and you think it could be HER2 negative 1 plus, then that patient will miss out on receiving trastuzumab. Oh, all right. Again, I went to the Twitter universe. I asked the followers, showed them the same slide of the micropapillary, just asking what would be the most appropriate HER2 IHC. And you can see about 71% of respondents out of 182 responded that this is indeed HER2 equivocal, meaning it's out there. But there's still about 20% who thought this would be HER2 amplified. They weren't wrong. They weren't wrong, but it did end up being fish amplified. But it's not true, complete, intense membranous staining. You see about 8% scored it as ultra low, thinking that it would be 1 plus. Thankfully, no one thought this was HER2 null. You can see that there's certainly some expression here at the cell membrane level, but this would be indeed HER2 2 plus and sent to fish. Lastly, I like to assess the stain intensity. Again, as we mentioned, this is a very strong. This is a part of the definitions for each one of those categories. So I've included here the objective and ocular magnifications, but intense staining should be easily visible at low power. We're talking about 2x, 4x. When we're looking at weak to moderate staining for 2 plus, you should be able to see it with using your 10x objective or your 20x objective. And when we're looking at the low levels expression, things like HER2 ultra low and null, we really want to go at high power using that 40x microscope objective lens and really scouring the entire tumor area for any barely perceptible staining, because that'll bump up the patient to an ultra low rather than a null. Lastly, there's no ego in this. I mean, if I ever have difficulty in deciding, I'll just show a colleague. I'll bring them to the consensus conference and I'll ask, hey, do you guys think this is 0? Do you think it's 1 plus? I'll even do it for 3 plus versus 2 plus. And sometimes we have a 2.5. But it really does help to show another colleague, especially when there is such importance to each one of these interpretations. I think, this protein became my favorite because in residency, one of my mentors, she told me, this is the time when you're really writing the prescription for the patient. And it's so true. And it really expanded our ability to prescribe when we're looking at things like PDL1. But when we're interpreting ER and HER2, we're really offering a different kind of medication for that patient, especially now with the null and ultra low. You're deciding whether or not that patient will get, trastuzumab deruxtecan or not. And, you're opening patients up to side effects and really to some benefit if they truly are. So really no harm in showing another colleague. And it really is a powerful tool to think about when you're just like a physician who's prescribing in the clinic. You still have to decide, ask your colleagues, do I really need to give lisinopril or not? And how good are we at the inter-observer variability? Well, this is a study from our colleagues over in Europe. This was published in ESMO Open. You can see that on the right-hand side, we're not so bad when we're looking at null and non-null, as we saw in the Twitter poll. But really in the middle pie chart, we can see here that null versus ultra low versus 1 plus versus 2 plus, we're really bad at it. And it's just, comes down to experience, coming down to time, coming down to what have you, the basic low levels of this assay, testing the real limitations of this assay. For one reason or another, we're not so great at identifying it, even amongst ourselves. So it really doesn't hurt to share the case with another colleague. So again, just to show you guys overall, again, the approach to HER2 IHC testing, and that really ensures that you get the right interpretation for the patient. Lastly, we'll talk about some future directions. So, as I mentioned at the start of the talk, development of new therapies, results of ongoing trials, that can easily throw this talk out of the window, right? I mean, we're all just waiting to see how trastuzumab deruxtecan will work in the HER2 null, patient population setting, in the hormone receptor negative HER2 ultra low setting. These are all things that I'm eager to look forward to. I'm sure a lot of you out there and our medical oncology colleagues are also looking forward to. So that's something to look forward to, but especially with the other Destiny trials that are ongoing. standardization of the HER2 low and ultra low interpretations. It's something that we need, as I showed you. It's really hard in those low levels of interpretation, especially with our assays. Is our assay even, meant for this, designed for this? It's something that I look forward to in hoping that we can standardize this. Maybe even if we all agree on something to show this in terms of our competency assessment and our proficiency testing. And lastly, this wouldn't be a modern day talk without mentioning AI. I cannot wait, as I'm sure you all are, to have AI help me find the ultra low tumor cell that's, has some low level of expression of HER2 at the cell membrane level, especially with those 30 cases. It would make it a lot easier for me. So I eagerly anticipate AI being incorporated and helping me out and finding out those cases, and even arbitrating in these very difficult kind of cases where we're deciding between 3+, 2+, and HER2 low and on ultra low and null. So I look forward to it. I'd like to end just with a painting. I studied classics in college, so I'm really only useful in a museum. This is a painting from Raphael, one of the masters of the Renaissance, and this is depicting the triumph of Galatea. So Galatea is shown here in the middle, enrobed in red, and you can tell this is a Raphael painting just from the stark color of blue. He really sort of just mastered this almost Tiffany-like blue pastels and the reds that are here. But here he's enrobed, Galatea in the center, a sea nymph in red, and Galatea had a steady relationship, had a boyfriend, and they were enjoying their life, and she was having a great time. They were on a date, and unfortunately for Galatea and her boyfriend, a Cyclops saw them, and she caught the eye, literally, of the Cyclops, the only eye, and Cyclopses are not very forgiving people, and they're very jealous type if you've ever met a Cyclops. And they do what Cyclopses do, and their method of choice for dealing with their problems is crushing them with boulders. It's a useful tactic, but I wouldn't suggest it. But Cyclopses have mythical strength and basically pulverized Galatea's boyfriend. Galatea, obviously distraught, not interested in Cyclops, had to think of a way to get back to her boyfriend, and so she used her sea nymph powers and transformed him into the river. And you can see all of these, this big festival here in the river. Galatea is on a chariot of a seashell. You can see the two dolphins leading her chariot. You can see the centaurs over on the right, partying. They're blowing the trumpets. You can see Pan on the left, blowing his sea conch, announcing that there's a big party. You can see the sea nymphs here and mythical sea creatures enjoying. And on top, you can see all the cupids with their arrows, obviously pointing towards Galatea, because I don't think you can shoot water with an arrow. And then you can see a cupid up there on the top left with more arrows, just in case one of them miss. And I think of this as a way of sharing with you the story of HER2. At first in the 1980s, we identified HER2 as a adverse prognostic marker, something that was mourned and bad news for the patient, to where the point where we have things like trastuzumab that's celebrated, and even low levels of expression. So, I think of this as sort of the triumph of medicine and the triumph of Galatea when I think about this. So I hope you enjoyed that. With that, again, I want to thank my colleagues over at the CAP Today for hosting this event. I again want to thank our sponsors, Roche, for having me and for making possible. And thank you again for listening.
Dr. Hoda, thank you so much. That was a wonderful presentation. And it is the first time in a CAP Today webinar that we've had Galatea and Taylor Swift mentioned. So that's a new conjunction, as we say.
It's a new era.
A new era. Many veteran pathologists have compared great surgical pathology to being an art historian and an art connoisseur. And I think you've showed us also that. So thank you very much.
Thank you.
All of you should know that we will be posting this webinar with full text and full audio in about a week at CAP Today online. And I feel sure that you'll want to review this. I would use it as a teaching for residents and fellows. It's just been a superb event. But with that, it's now time for a few questions. Let me first ask a question regarding the many slides that you showed at the outset as showing the progressive improvement of patient outcome and survival with the various modalities of treatment as they've come online.
Mhm.
Do the improvements in outcomes in all those Levy-Jennings shot tend to hold up for all age and ethnic groups?
Sure. I think that's a great question. I don't think these trials were powered enough to tell any difference, right? You can just see even the order of patients who are in the initial trial was 11 for HER2 amplified. And when we had things like trastuzumab deruxtecan, we're looking on the order of 100 patients or so that were included in these trials. So I don't think it was powered enough to tell if there's any difference in age and ethnicity groups. I think that would be very interesting to show. Certainly, as we know, tumor biology is not agnostic to these things, and I think it would be really helpful to show. Certainly even in BRCA, I'd be interested to see if there's any data in that. So I think it's something that we'll see further on as we get more developments and more experience, certainly with our ADCs.
Thank you. Thank you very much.
Mhm.
We've got a couple of questions. I'm going to try to combine them for you. Um, and the question here is, um, how do the ADCs differentiate between very low normal expression in normal epithelial cells versus HER2 low or ultra low
Yeah, I
tumors?
That's an excellent question, right? And I think that's where you get things like medical side effects, right? Because it isn't just using it to drive the tumor, but it's using it as a homing signal. So, as we showed, even normal breast epithelium cells do have some level of HER2 expression, and I know the DAISY trial, for example, showed that even in tumor, that low levels of HER2 expression can have some sort of benefit for trastuzumab deruxtecan, ADCs usage. So I don't think the ADCs differentiate between very low normal expressions and ultra low. That's why we have to be very careful when we're talking about, can we select the appropriate patient populations? But I am very curious when we do get data on HER2 null patients, if there is some level activity, because it may not be that there are very low levels of normal, but that because of the lower assay, limitations, that we're not seeing that low level of expression. Maybe there is some sort of increase of it, as we talked about. It is a very potent driver for cell division and uncontrolled cell growth. So I'm sure at some level these tumors are using it, and it may just be used as a drug delivery system. So that's a great question, but I am curious how it will behave in the HER2 null setting.
Very good. Thank you.
Yeah.
We have another question, put very simply. Uh, given a case where you have less than 10% complete intense staining on IHC,
Yeah.
how do you score that currently in your mind?
Sure. So what I'll do is I'll make a comment that says that this is heterogeneous for HER2, that there is a small proportion of patients of tumor cells that have complete intense membrane staining. So I'll actually call it sort of HER2 heterogeneous and mention the amount of tumor cells that are positive. Whether if there's a overarching score of 2+, I'll send it to FISH, but at least the medical oncologist and the patient know that they have some sort of level of HER2 positivity to address. And this makes sense, especially, if we're talking about the metastatic setting. In the primary tumor, it may be a very small proportion of tumor cells that are HER2 positive, that are HER2 3+, but that may end up going to the lymph nodes, that may end up going to the bones, because it is such a potent adverse prognostic factor. And that's why we sort of have to keep testing these patients, making sure we really are getting the full picture of HER2.
Thank you.
Mhm.
Thank you. You have very, very eloquently displayed the history of improved testing, improved treatments, etc. And now tell me how you deal with referring particularly oncologists and surgeons who are very anxious that their patients have every chance to receive the new drugs, the ADCs, in the case where they're maybe equivocal, ultra low, even null. I'm sure you get that question
Yeah.
on a frequent basis.
Absolutely. So, I mean, for many of my colleagues who I'm sure do PDL1, you sort of want to give, you want to find the positivity. So for me, when I'm looking at low levels of expression, I really do take the time, because that really, in my experience with my, as I showed you the study from, Dr. McIntyre and I, it really comes down to the time that you spend on finding and looking at the tumor itself to find that one tumor cell that's positive. So I try my utmost, as my mentor had mentioned, you really are writing the prescription for the
Hmm.
patient and making a big difference. So, we here, I'll take my time, I'll look, I'll spend 10 minutes, even depending on the tissue size, and really scour and look for it. And if I'm ever in doubt, again, I'll show a colleague and say, hey, what do you think about this? Do you think this is positive or negative? Am I hallucinating? Is it cytoplasmic staining?
Hmm.
And that really is important to ensure that the right patient gets the right medication. Because again, these are not without side effects and certainly without financial toxicity. So I really do take the time, and I think that really is the only thing you can do until AI helps. That's all I can do.
Very good. Thank you. One
Absolutely,
last question for you here. And if you didn't get your question answered, our friends at Roche and I'm sure Dr. Hoda will be happy to get your question answered for you. So
absolutely.
don't despair if you didn't hear it yet. But our final question today,
Yeah,
uh, can you comment on non-specific strong cytoplasmic and nuclear staining? And then do
yeah.
you perform FISH?
Yeah, absolutely. I think that's a great question. Now, I'm smiling because me and my colleagues, Dr. McIntyre, and actually my father over at Cornell, we have been trying to publish this data for so long, and no journal will take it. So if you know someone in an editorial office who's interested, that would be great. No, but we have shown this is anecdotal data. This is my favorite kind of data, historical, just personal experience. We have sent these tumors that are certainly, a lot of them have an apocrine in morphology for one reason or another. It may be that it's taking up the stain, just the protein as it's just granular. I'm not quite sure, but we have sent these over to fish just out of curiosity from a scientific perspective, just to see our hypothesis, and they've all been fish negative. So
Ah,
we've collected many of these African tumors, and so there is no published data, but I can assure you I have tried to publish it for now probably 5 years,
okay.
to show that this is non-specific and by no means has any translation to HER2 status. Now, whether they respond to the ADCs, I'm not sure. African carcinomas can be HER2 amplified, as I'm sure you know. I'm not sure if these, I mean, at least in the metastatic setting, these can get trastuzumab deruxtecan. But that's a great question. I would love to publish it.
Okay. Well, thank you. As you are well aware, the college also has a journal. Your father's
Yes,
on our editorial board, by the way, not to be too inside baseball, but
I
there's
won't
many,
mention which journals have
right,
have
right.
rejected it.
Okay. Please don't. But there are something like 58 pathology
Yes,
journals in the citation index report. So you keep trying, all right?
absolutely. Persistence
Please.
is key.
And listen, thank you so much for this last word. This has really been a pleasure for me. I need to wrap up now, but I obviously we are all in the debt of Dr. Hoda. This has been a really magnificent presentation, giving you the whole history and development and a lot of markers pointing to the future, which I'm sure we'll be discussing soon and will be in print soon. So with that, I want to thank Dr. Hoda. I want to thank Roche. They step up to the plate marvelously in this area and have done a great job. I want to thank them for their educational grant in support of this program. And finally, I want to thank everyone who's taken the time today to join us. I know how busy everyone is in laboratories today. We're always very gratified when you take time to join us for these webinars. I'm sure that you've enjoyed this and will be referring to it. So finally, just to wrap up, thanks to Dr. Hoda, thanks to Roche, thanks to all of you. And with that, I'll bring today's webinar to a close.